Hi, I'm Tom Marino. At Conresnick, we believe that all citizens need to be informed about the issues that affect their daily lives. That's why we're proud to support the programming produced by Caucus Educational Corporation and their partners in public television.
Pain and palliative care, improving quality of life, next on Caucus, New Jersey.
Funding for this edition of Caucus, New Jersey has been provided by Hackensack University Health Network, the law firm of Gibbons PC, Johnson & Johnson, St. Peter's University, the Jesuit University of New Jersey, Wells Fargo, and by New Jersey Manufacturers Insurance Group, auto insurance, homeowners insurance, and banking under the principle of stewardship. Promotional support provided by NJ Biz, All Business, All New Jersey, The Star Ledger, and NJ.com, Everything Jersey. And by New Jersey Monthly, the magazine of the Garden State, available at newsstands.
Welcome to Caucus, New Jersey. I'm Steve Adubato. Palliative care improves the quality of life for those facing life-threatening illnesses. Here to help us in the studio to better understand the benefits are Mary O'Dowd, Commissioner of the New Jersey Department of Health; Dr. Joe Contreras, who is Chair of the Pain and Palliative Medicine Institute at Hackensack University Medical Center; Ray Medina is a patient being treated with palliative care; and finally, Colleen Bell, Founder and President, New Jersey Palliative Care Advanced Practitioners Consortium. I want to thank all of you for joining us. Throughout this program, you're going to see a couple websites. Use them. This program is dedicated to helping you better understand what palliative care really is all about. It is not hospice right out of the box. We're going to explain what the difference is. The rest is up to you to go out there and get the information. That's why the sites are up. By the way, Doctor, what is the difference between palliative care and hospice?
Palliative care is a medical specialty, and what that means is that palliative care is just like nephrology, just like pulmonology or cardiology. We are medical specialists, fellowship trained, that perform services that are aimed at quality of life and human suffering. And we can perform these services during any time in one's lifetime. So we're not limited by any time frame. The one thing that is important is that the person be fairly ill. We typically are involved with patients who are seriously ill. However, we do expect that they might survive their illness, which is a very big distinction with hospice. Hospice is limited by the last 6 months of life, as is end-of-life care. And as you pointed out very succinctly, palliative care is not hospice, it is not end-of-life care. A doctor must qualify you or make his best estimate that you have 6 months left to live, and then you could qualify for the hospice benefit.
Okay. Now Ray, just to be clear, you had cancer.
Yes.
Extreme pain.
Mm-hmm.
Your professional background is fascinating.
Mm-hmm. Thank you.
You are a building maintenance supervisor, and Commissioner, is it not a fact that he is a salsa musician?
I've heard such.
Yes.
You were in extreme pain.
Yes, sir.
And therefore palliative care was an option for you, so you were a candidate for it.
Absolutely, yes.
What was the difference between the 2 years of extreme pain that you were experiencing before palliative care and what happened 4 months ago when you went into the program?
Well, I had a lot of extreme pain, abdominal pain, due to the surgery, because they removed 18 inches of my small intestines and 4 inches of my colon. And I used to go through a lot of pain, couldn't work, couldn't perform with my band or nothing. I had to just kind of set back, and pain was like 24 hours a day. So then my doctor referred me to Dr. Contreras.
I think we're looking at a shot of you and your band performing right there.
Oh, yes, that's
the Ray Medina Orchestra, I like that.
I've been with my music for 50 years.
That's part of your life.
Yes. Doctor started to care, and little by little, the pain started just dissipating, going away. I was able to go back to work and actually start performing all over again.
So what is it, pills, shots? What is the care?
Well, the care is a combination of medicine that he prescribed, a little combination. We tried, several things, and then we nailed it. I use a patch, which puts like medicine 24 hours a day into my system in combination with a pill. And that actually makes me function.
Change your life?
Changed my life totally.
Commissioner, help us understand something. Why is palliative care such an important piece of the equation for you and your colleagues in the Department of Health?
Well, one of the reasons that I made palliative and end-of-life care a priority for myself as commissioner is because so many people in New Jersey, both individuals who could potentially benefit from palliative care, as well as providers who could ensure that that was part of the treatment that they were giving to their patients, don't know enough about it. And so trying to engage the community, individuals, regular people in the community, as well as providers, in a conversation about why it's so important to incorporate palliative care in the treatment of disease where there's pain or discomfort of any kind, as well as a conversation about end-of-life care, which may or may not be part of a palliative plan, but is equally important to ensure that individuals are honored, that their wishes are respected, that the providers know what patients want, and that family members have an understanding of what each other in their family wants, and so that they can be ensured that their wishes are honored at the end of life, which is really important.
For so many?
I think the conversation is hard, and we want to make it easier and more commonplace for people to start to have that discussion. It's very, individual, and people are very passionate about what they may want. But the worst thing is if you never have that conversation, because then a crisis may occur and you have a situation where people don't know who the decision maker is and they don't know what that individual may want. And it's really important to have that conversation early and often, because as you go through the life cycle, your wishes may change. And so we know that there are some tools out there for people, but one of the things that Governor Christie has done is he signed a new law, the PULST form, which is the Practitioner's Orders for Life-Sustaining Treatment.
Hold that, Commissioner. As you talk about it, the website is going up right now. As Commissioner O'Dowd describes it, go on the website, important information about this new New Jersey law. Go ahead, Commissioner.
So what PULST is actually...
Stands for again?
The Practitioner's Orders for Life-Sustaining Treatment.
Go ahead.
And so what it is it's a medical order, something that a patient and a provider, an advanced practice nurse or a doctor, talks through with the patient to decide what kind of medical treatment do they want to have or not have near the end of life, so that it's all clear to everyone. And this is something that people can bring to their physician's offices or their nurse practitioner office as part of their routine visit and talk to their provider about, so they're fully educated and can have a thoughtful dialogue. And then they can share that form with their family members. And it's a medical order, so it has to be respected and honored by whatever healthcare facility or EMS personnel that comes to treat that patient.
You have it with you?
Yes.
Is it different from an advanced directive?
It is different, but it can complement an advanced directive.
They don't conflict?
They shouldn't conflict because your wishes should be similar.
Same message?
Right.
Jump in here, Colleen.
It's just to make sure I understand, PULST is for 2 years life expectancy, correct? And advanced directive can be done when you're 40 and could be effective.
Because I have an advanced directive.
Exactly.
PULST would not be right for...
PULST is ideal for individuals who are near the end of life, so approximately the last 2 years of life. That's not always an easy thing to figure out.
How does one know all the time?
But usually people who are older in age or are dealing with a life-threatening illness would be an appropriate potential candidate for the use of this form. And it's something that a physician or an advanced practice nurse actually fills out with that patient, which really talks to what kind of medical treatment they might want.
A clinical professional should help.
They have to. It's an order form.
Okay, jump in here.
Many times in the hospitals, these PULST are being filled out now because they have just either been diagnosed with a life-threatening illness, or they have had repeated hospitalizations, and the conversation needs to be started. What are your goals of care? What do you want if you need to be resuscitated? What do you want if you possibly need CPR? Do you want life-sustaining measures? And I think the doctor's office is an important time, but also in the hospital, nurse practitioners and medical doctors are filling out these PULST forms. They are new in our state, so we're getting used to them. But
describe your organization's role in all this. Very important.
My organization is a group of advanced practice nurses in palliative care across the state. We have approximately 23 members. We're a nonprofit. We represent about 18 hospitals, 18 to 19 hospitals. And we meet 3 times a year to help promote palliative care, and frankly, as a support group for our own individual practice. Palliative care can be a solitary, at times a solitary field in a hospital.
What does that mean?
Well, we are solo practitioners, many of us. Some advanced practice nurses run the hospitals, run the palliative care in the hospital.
Well, I'm going to say it correctly. It's palliative care. I said palliative care.
Palliative is correct.
There's the I. There's the I. Yes.
Okay. Got it.
That's correct.
It doesn't matter.
No,
Educating is hard enough. Okay? But these nurses trained in this field,
right?
Okay, their job is to educate patients who are dealing with these issues, helping them through these forms. There's a big emotional side to this.
Oh, there's well, palliative care is it is a holistic approach. It's a multidisciplinary approach to the patient-centered care. It includes emotional support, physical support, psychological support, spiritual support. So there is a whole emotion that goes into treating.
Which is why you have a whole team. Describe it.
Yes, well, you know, and just to add to that, it's very interesting because if you look at the paradigm of medicine now,
The model of medicine.
The model of medicine, there is not a specialty that deals with the human being and human suffering. So that's sort of a new concept for physicians in the hospital. We're not focused on one organ. We're not focused on the heart or the lungs or the kidneys. We're focused on the human being. And that's what makes palliative care so special. And it's important to know, too, that nurses certify in this subspecialty as well. As Colleen is an advanced practice nurse. So it's not just physician-based, and she pointed that out nicely. And I think 3 important things that are that should be kept in mind when you talk.
Hold on, before you do that, it's great that you're going into that, but who else is part of your team so we can understand
so
who else
you know,
it
could certainly be nurse-led, as Colleen leads her team. It can also be physician-led, and then we may have additional nurses, additional advanced practice nurses or physicians that are a part of the team, along with chaplains, along with a bioethicist, along with a nutritionist. Sometimes there's a pharmacologist that's involved because the medicines can get complicated.
All available to the patient.
Yes, a social worker, a case manager perhaps.
All available to the family as well.
All available to the family as well. And sometimes we have a hospice coordinator. When the time comes that a patient might be deemed hospice appropriate, a hospice coordinator can help with that transition.
All those pieces are important. By the way, impact on your family, particularly over the 2 years that you were in extreme, excruciating pain?
The impact was great on my family, you know, but I've had such wonderful family support. You know, my wife, my daughter's with me constantly. She's my backbone, you know.
Right.
So she's here in the studio with me
She
today.
is?
Yes, she is. And
Is that Gina?
Sheena.
Sheena, I'm sorry.
Yeah. She's like she's my life. Let's put it like that. Yeah,
I hear you. I got one at home.
Yeah, it was extremely hard for them to see me in those conditions. I'm a very active person.
You don't actually have 6 grandchildren, do you?
Yes, I do.
That's just not true.
Yeah. My oldest grandson is 18 already.
That's wild.
Yeah, but you know, the family support is very, very, very important. Also, and you know, with the support I get from the doctors.
But you were concerned about the impact on your family, though, too.
Oh, absolutely. I don't know what was going to happen. You know, if I was going to wind up in a hospital, what was going to happen to my family, and this type of the situation. So it was very hard.
Jump in,
You bring a really important point up, and that is that the whole family is part of this conversation and planning around end-of-life care. Every family's dealing with it at some point or another. And part of planning around end-of-life care is having that conversation with your family members so that they feel supported by you as the patient, potentially, and understand what you would want. So if they're in a situation and they're making decisions on your behalf, or working with you as the patient to figure out what's best for you and for your family into the future, you're doing it together. And that's why it's so important to have this conversation, whether it's around the dinner table, after you're dealing with another family member that's going through something similar, to routinely have this conversation about what are your wishes around end-of-life care, and what are your issues or wishes around being ill or sick. And palliative care in particular is about the entire family. It's about making sure that the patient is well cared for and comfortable and has a high quality of life, and that has a significant impact on the entire family unit.
It's interesting. We talk about the role of nurses. We talk about the role of physicians, social workers. You talk about the chaplain. You talk about a bioethicist. How do you see, and how do you believe the governor sees the role of state government? Because you are not advocates of big government.
Right.
How do you see the role of state government in this discussion?
Well, I think what government can provide is some rules of the game and some tools for providers. So, for example, with this new order, this POLST order, we provide a tool for both patients and providers to facilitate a conversation so that something that sometimes is difficult to approach is easier. We engaged the entire community of providers in developing the form that would be used, and give it to the provider so that it's something that the providers can use to talk to their patients about. Patients can bring to their providers if they want to make sure that they understand what their options are, and that they can also have the ability to make sure the providers will honor them. This is a part of the patient's medical record. After it's completed, it's a medical order. So it's put into the patient's chart. So if the patient wants to be at home and comfortable and doing well there, then EMS has to honor that form.
They have to.
They have
by
to
law?
honor by law.
And that's new as of?
Governor Christie signed the law in 2011. We went through a process of developing the form, and just recently we reminded all the providers out in the community that it's now the law and they have to honor it. And so it's voluntary for any patient or provider to fill it out, but once it's filled out, it is mandatory that all providers across the entire spectrum honor that.
You know, it's interesting, as the commissioner talks about this, let's put in perspective, Colleen, you can come back into this conversation, it's important. New Jersey does not have the best track record, let's just say, in end-of-life situations. New Jersey has the highest end-of-life, highest cost. We spend more money in the last, I'm not sure how many months, I believe the last 2 years. Help me on this, Commissioner.
New Jersey ranks #1 for costs for patients in those last 2 years.
How about outcomes?
In addition, we have the highest number of visits by medical specialists in the last 2 years and last 6 months of life, and there's no impact on having improved outcomes.
Jump in.
But I think we're improving as a state. I truly feel that, I believe it was 2006, 2008, we were the top for spending, as Commissioner just said. However, in the last 3 years, our hospice enrollment in New Jersey has increased by 3%. So and I've been in palliative care and hospice for 25 years. I truly feel that palliative care, New Jersey has gotten the word that we need to wake up and quit spending money.
Well, we're playing catch up, let's be clear. There have been a lot of years we were spending a lot of money in end-of-life care without any significant positive impact on outcomes. We agree.
Up until 2008, I've seen a
dramatic difference in the last 4 or 5 years.
Well, incremental.
Okay.
Incremental, but we're improving rather than decreasing.
Got it.
Or rather than having more.
And you believe this palliative care initiative, or these initiatives, this public awareness, is a big part of that?
I do, because as Commissioner said, we're getting the conversation started about what these patients want.
More options.
And yes, and we are taking the time to sit down with families and patients and saying, what's important to you at the end of life? Or really, what's important to you right now as you face a chronic disease?
Or even before.
Right, but that's a little harder.
You're
right. I feel when they have a chronic disease facing them looking at them in the face, I feel if they're accepting of their diagnosis, I feel that they're more willing to have an open conversation.
Well, let me just put this out there. When family members see other family members struggling and facing a chronic disease, I understand what you're saying about the need to have it. There's a pressing need to have it about that family member. You obviously had it.
Right.
You made a switch 2 years in, and luckily good things happened for you, and we hope good things continue to happen. But doesn't that send a message to everyone else in the family who's not facing that chronic situation, that chronic disease or illness, that they need to be having that before they face it? Why wait?
There's no reason to wait, and that's the whole point. The sooner that you're having these important conversations, the sooner that you're making important decisions, the better off you are as far as what your needs are, as far as what your values are, the desire that you have that those needs and values be respected, and that you may not want certain treatments because they might have a negative impact on your quality of life. So that whole aspect of coordination and communication and decision making is one of the key points that palliative care can do to help healthcare.
And the conversation evolves over time. So when you're younger and feeling healthier, you're going to have one way of looking at this and a different conversation.
Seems abstract.
At the point in time where you're confronted with a diagnosis that could be life-limiting, like cancer, you're going to have a different kind of a conversation because it's going to be more specific about medical treatment and care. And so it's important to continually have this conversation with your family and loved ones because it will change over time.
For you, what was the conversation like with your family without being too Oprah-esque, if you will? Not Oprah, love you, but I'm not looking to make anyone cry. Go ahead.
Well, the conversation was you know, like, what's going to happen in the future for me? You know, how could I say this? It was very, sorry, it was very painful for me, you know, and to see the reaction my family was taking because I don't know if I was going to live.
You did not?
I didn't know if I was going to survive this. It's a small percentage of carcinoid syndrome. That's what I have, and I still have the tumor
in your intestine.
It's a tumor in my intestine, which it's still it hasn't grown, it hasn't shrunk. It's stable. Right now it's stable, okay? And so we still don't know if they have to go, once they shrink it down to a size, maybe they could surgically remove it. But up to this point, there's no, how could I say this?
You have no guarantee right now.
No guarantee,
So the fact that you look as good as you look right now, not just to me and everyone here, but to, I want to say millions, but we're public television, to the millions watching right now, to the many people watching. That doesn't stop
4 or 5
you
months
from,
ago, I wasn't like this.
What do you mean?
I lost a lot of weight. Dr. Owens, I was very skinny. I wasn't eating. I wasn't doing much. And he has brought me up. I don't know.
Would you have appeared with us 9 months ago?
I don't think so. You know, I didn't look presentable enough. I mean, I was too skinny, and you know, I didn't want to go out. I didn't want to look at nobody. I didn't want to do nothing. It's just like I'm gonna die. Let's put it like that.
Your life has changed in many ways.
Dramatically.
Biggest way.
Biggest way. When I came to the doctor, I told him, "Listen, doctor, I would love to try to go back to work, but I can't do it. The pain is there constantly. I can't deal with it. I don't sleep. I don't eat well." And he said, "Let's go this route. Let's try this medicine. Let's try that." And we started. And within 2 months' time, my life just started changing.
That's palliative care.
That's palliative
if it's done well, if it's done right.
It's done right. I mean, your life is going to change extreme.
What was it like for you and your team to see Ray?
Well, I told Ray 2 things, and I usually tell most patients this. Number 1, we're going to restore quality of life. Don't worry about it. And number 2, we're going to get you functional.
Why were you so confident?
I think you have to be. You have to have that confident flair when you're dealing with somebody to give them the encouragement to fight through what they're dealing with. And it's multiple domains of suffering that occur. It's not just physical.
Mm-hmm. What do you mean?
Well, you know, suffering can occur in emotional domains. It can occur in spiritual domains. It can occur in existential domains. You know, at a certain point, he wasn't sure he was going to live.
Could some people just give up?
They could, absolutely.
And you're fighting that?
Absolutely.
Commissioner, let me ask you, so much of your work people think is public policy, is regulatory, is governmental. A lot of it's human, isn't it?
Yeah, and I think this was an issue that I saw in my own life, in my own family, as something that sometimes worked really well and other times not so much because of poor planning. And the role of commissioner, you're able to bring a different level of conversation to the community. In particular, as Commissioner of Health, you can talk to providers in a different way. They'll come and talk to you, and you can engage them in this conversation. So, and I know that there are doctors and nurses, like these two people sitting here, with the skills and power to improve the quality of life for so many people in the state of New Jersey, whether in the middle of working on the cure or the healing of a disease, or near the end of life. And I see my role and the power of my position to choose this issue to really raise awareness that this exists, so people can start to have the conversation at the dining room table, and that providers will start to have this conversation as well.
I want to thank all of you. You've done a great public service, particularly you, Ray. Thank you. All the best to you.
Thank you.
The preceding program has been a production of the Caucus Educational Corporation, celebrating 25 years of broadcast excellence, and 13 for WNET, NJTV, and WHYY. Funding for this edition of Caucus New Jersey has been provided by Hackensack University Health Network, the law firm of Gibbons PC, Johnson & Johnson, St. Peter's University, Wells Fargo, and by New Jersey Manufacturers Insurance Group. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. Caucus New Jersey has been produced in partnership with TriStar Studios.
There is a place that pushes beyond traditional thinking to take medicine further than ever before, where science and creativity work together to give heart and cancer patients new possibilities, and researchers discover options for children who once had none. A place that proves every day that impossible is just an opinion. Hackensack University Medical Center, where medicine meets innovation.